ibogaine, ayahuasca, kratom. We had our speaker ketamine. Today we come full circle with one of the more common ones that we hear. It's called psilocybin, so which has moved from counterculture to clinical research with surprising speed. Today, I'll briefly review mechanisms, data, and safety and screening considerations. So, this is about understanding the pharmacology well enough to counsel patients intelligently. So, psilocybin is a prodrug found in species such as Psilocybe cubensis. It is converted into in vivo to psilocin, a 5-H2A receptor agonist, a tryptamine alkaloid structure related to serotonin, which is, as we know, can produce hallucinations or hallucinogenic and traditionally used for psilocybin usually are for rituals. And the more common ones that we hear were the pre-Columbian Mesoamerica or the Aztecs. And for the US, Schedule 1 is still the same classification where it stands since 1970. And it's, again, Schedule 1 is a drug that has no current accepted medical use and a very high potential for abuse. Pharmacologically, this produces cortical glutamate release, increased neural entropy, disruption of default mode network activity, and increased global connectivity. Neuroplasticity window lasts days per weeks post dose. And the reason for that is dendritic spine growth has longer lasting compared to ketamine. It functions as a network level modulator, not a conventional antidepressant. So the neurobiology here, functional MRI, has shown in terms of the studies had been exploited by Johns Hopkins University and Imperial College of London demonstrated that it decreases default mode network integrity, increases cross-network communication, reduce rigid self-referential processing. Even preclinical data shows that it increases BDNF signaling, enhancing synaptogenesis and even dendritic spine growth. So this aligns with observed psychological flexibility post-sessions. So clinical data, MDD, so major depressive disorder, 2020 randomized trial from Johns Hopkins demonstrated a significant reduction in grid ham scores. And rapid onset was seen within 1 week. It was also sustained in terms of benefits at 4 weeks post-session. And again, another study most advanced in terms of the indication is treatment-resistant depression. So Compass Pathways, or this is the name of the study, which is now in phase 3 program, which was actually announced just February 17, 2026. And in London, so they're actually showing that the results are comparable to superior effect size to even escitalopram in some measures and rapid symptom reduction. So durability extending weeks to months in subset analysis. And they use it on cancer also. Johns Hopkins and NYU showed that it lowers the stress of cancer patients. Again, sustained effects of around 6 months, even addiction. So how powerful it is, single or 2 macrodoses. Plus, you do psychotherapy along with this. Thus, the effects, as we call it, to help with depression now ensues. Safety, psilocybins appear physiologically safe in screened populations. There was no noted, accidents between from now to before. However, contraindication should be bipolar, psychotic disorders, unstable cardiovascular disease, active serotonergic polypharmacy, so SSRIs. Adverse effects are primarily transient, anxiety, blood pressure elevation, psychological destabilization in vulnerable patients. State level, where are we at in the US with this? Oregon has a fully regulated psilocybin service program that they actually have. Colorado has a regulated natural medicine program for this. And also Australia and the US, so outside of the country, has authorized prescribing for TRD by psychiatrists since 2023. Why not us, right? And even Canada, Section 56 exemptions are there for their use. As a finale for this, psilocybin is best understood as a serotonergic network disruptor, a catalyst for emotional processing, a high-intensity, low-frequency intervention. So the emerging data are compelling, but outside of regulated settings, variable remains high. So as integrative physicians, our role is not for advocacy, but informed risk stratification and patient education. So that's our Leak of the Week.
Great. Okay. Thank you so much. Where was I before we started? I forget. Anyway, so this week's a little bit different. So Dr. Victor Klausner is one of our regulars. And Victor, I think weren't you president of the of NOMA at one point, Nevada Osteopathic Medical Association?
Twice.
Huh?
The first time, yeah, I was twice.
Twice.
The
Okay.
first time was voluntary. The second time it was damage control.
I
You know
see.
how that goes, right?
I know how that goes. So Dr. Klausner's been one of my students, and he brought me a case that I thought was pretty interesting, and I thought we could bring it to the group. And hopefully, I know this forum sometimes doesn't isn't quite all that interactive, but we want to present it as what would you do in the audience at various intervals. So we want you to put your thinking caps on. We'll see how it goes. If it doesn't go too well and nobody volunteers anything, then we'll just keep going. So Victor's going to present the case. He's going to present her symptoms, and then I'm going to do some of the academic portion of it.
Bill,
Um,
Bill, I that wasn't the plan.
that wasn't the plan. It got
No,
changed.
you're gonna do your part, and then if there's time remaining, I was gonna do that genomics piece on.
Oh, so I'm doing okay. All
Yeah, yeah,
right.
yeah.
You see how well organized we are here. All right, so that means I don't get to introduce you then, or do I?
No, you introduced. I I'm
Well, they all
totally.
know who I am. I'm the big mouth who drives everything here every week. So
Yeah.
Dr. Klausner's been 25 years in Southern Nevada as occupational and rehabilitation medicine specialist, and then he came over to us at the dark side, and he's a leader now in integrative primary care and non-surgical sports medicine. He's known for listening closely, looking deeper, and blending evidence-based diagnostics with root cause strategies that promote healing, energy, and long-term wellness. Dr. Klausner shares with us his insights in a commonly seen, frequently misdiagnosed and treated, and complicated case history, which I guess I'm going to be presenting now. So his goal is to help every patient improve function, reduce inflammation, and optimize performance physically, mentally, and metabolically. Isn't that what we're all supposed to be doing, right?
Mhm.
All right, gotta admit some people. Too often, patients are rushed through brief visits, handed prescriptions without answers, and referred from one specialist to another. Dr. Klausner seeks a better way. Over time, he's developed a model of care that treats the entire person. His integrative approach combines conventional medicine, osteopathic expertise, acupuncture, hormone optimization, regenerative therapies, nutrition, and performance-focused recovery. Um, and we won't go through traditional healthcare. They have symptoms and they whatnot. So Dr. Klausner, welcome to our group. Welcome to the dark side. And so you want me to go first? Is that it?
Absolutely, yeah.
Okay. All right. So you all know me. So this was a really interesting case that he brought me, and what I thought it would be interesting for the group to so hopefully participate. Now let me find it here. There we go. Okay, can you all see the slides here? Should say a tale of two syndromes.
Nope, we've got a lab slip.
You got a lab slip.
Yeah.
All right, let me try it again. Uh, Stop share. All right, now you see me.
Oh, yeah.
I see I have Victor here. Okay, let's try it again. How about now?
Yes.
You got it now?
Got it.
Yes.
Okay. So it says a tale of two syndromes. And like I said, sort of gave it away here in this little picture that we drew. But I think it covers a lot of the ground that at least the routine stuff that we cover, not some of the more complex stuff. But it covers a lot of the ground that we cover, and I think it's illustrative of some of the things that we do. So this is a young lady. She's 25 now. Um, she actually came to see Dr. Klausner at age 25, but her medical history begins at age 18. And so we traveled back in time a little bit, and we're gonna show you how this, these issues kind of build. We're going to look at conventional medical care versus what we do. We hopefully you'll get an idea. Those of you that are either new to this or fairly new to this, or not in the hormone optimization world, get an idea of what we can do, and looking at things through a hormone, what I call a hormone centric lens. Will broaden your perspective. We live in the age of specialization. We have a gastroenterologist, they go do gastroenterology things, and then you have an endocrinologist, and they do endocrine things, and never the twain shall meet. And we're gonna show you how things are linked together. So we're going to talk about some medical issues. We're going to talk about some psychosocial issues. We're going to look at some diagnostic tools, and we'll give you some of our treatment protocols. Okay, and I hope there'll be some participation along the way. Some of this was CME, so I don't get paid by anybody. So this is our patient Serena. She's presently age 25. But her story begins, like I said, at age 18. She was kind of a tomboy as an athlete. She was very disciplined. She was meticulous in her schoolwork and her after-school activities. She was reliable. She had an after-school job, and she was shy, but she was very friendly. She was a good student, and she also played softball, soccer, and lacrosse, and she earned an athletic scholarship to Boston University from those skills, and also ended up with a master's degree also. So she was raised in a devout Catholic home with strict expectations around socializing and social boundaries. She rarely had any dates, and in a worldly sense, she describes herself as being inexperienced. She had a traumatic close call with a male acquaintance at age 18. She didn't really go into it, but she's been increasingly guarded and hypervigilant ever since. And she says that she has some panic attacks when she remembers the situation, and she ends up with skin rashes. She ends up with stomach cramps, and hyperventilation. One time she had passed out in a grocery store when that situation came up. In her dorm room, she was known as the Ice Queen. Around age 18, 3 months into her freshman year, she began experiencing sudden unexplained anxiety and severe itching and cystic acne. And this sort of shattered or shook her confidence and her social comfort. And she did her best to hide her symptoms throughout her first year of college. So first question is, how do we determine what kind of approach would be best for this particular person? Are we sympathetic, or are we a little bit more stern? Okay, and the real question is, how can you gain this patient's confidence that we are competent to handle her care? Remember, she's had these symptoms now for 7 years, and she's been to a number of practitioners, medical doctors, psychiatrists, psychologists, and body workers and whatnot. And she's very wary. One of the things is, she's been to many places and she hasn't gotten anywhere. And she feels sort of taken advantage of. People have taken her money and basically told her there wasn't anything they could do for her. So, okay. So, the one of the antecedents of all of the of where we're headed is that she had this sort of unexplained anxiety. So, does anybody in the group have any diagnostic or diagnostic either way look at this? What comes with uncontrolled pruritus, shortness of breath, cystic acne? Also, she had some cold sensitivity. And what could some of the possible triggers be? So again, I don't know if this forum is, you can do it in the chat. You can just sort of talk out loud.
How are her periods?
Her periods are regular but heavy. And she gets a lot of pain before the 2 to 3 days before her period comes on, and she gets a little bit of an aura or a headache also, probably about day 24, 25 of her cycle.
I mean, what I wrote in the chat is that my first thought is that amnesia is part of the diagnosis of PTSD. So she may not remember consciously what happened to her at 16, but her subconscious and her body may remember.
Mm-hmm. Right. I mean, it does. Yeah. Panic attacks, sympathetic overdrive. Right. That's kind of what we were looking at.
Yeah.
There's no details on what happened to her, this traumatic event.
She was pretty guarded about it, and
I think she was very embarrassed. She's a very like kind, sensitive person, but she doesn't want to share too many details.
Yeah, I'm guessing it was some sort of sexual unwanted sexual advance. That's what I'm guessing. Would that be right, Victor?
Yeah, it was her freshman year in college at UNR, actually.
Mm. So
First time out of the house.
yeah, first time out of the house, and it can be a traumatic experience, especially if it's someone who's brought up in a strict religious background,
Right.
and has is not been out in the world. So,
Right. But I think that the bottom line in terms of this situation, you have to be completely sensitive, try to be supportive, and reassure her that you're going to try to get to the bottom of it and follow your instincts, get all the testing. Obviously, there could be thyroid issues and other hormonal stuff going on, along with the cortisol spikes that come with the stress and anxiety, college, and PTSD, and all of it. So,
right.
the key
And of
thing
course,
is you got to get the
childhood.
testing.
You've got to go to the childhood.
Yeah.
Yeah, well, like I said, we did ask a lot of questions, and this is kind of where her symptoms sort of began. So
I missed it. Did somewhere along the way, did somebody stick her on a bunch of antidepressants?
they tried, but she didn't do well on them. And then the gynecologist wanted to put her on birth control pills, and so that made her ill also. She was given Zoloft at one point. She was given Xanax at another, and she didn't do well on any of them. So
We could do
but
the
I think
genetic
this is
testing.
this is a pretty good example of God didn't make a Zoloft deficiency. You know,
I was president.
there was triggering events here, obviously, and the symptoms that she's having, really, at least in our world, have a fairly predictable course that you can follow. I think that's part of what we wanted to bring out. And so Dr. Richwine says hormone imbalance, obviously, so do the blood work, which is what we did. But from what we heard last week from Dr. Taylor, we shouldn't be doing blood work. We should be doing saliva tests, right?
Yeah.
But
Yeah.
she doesn't have that kind of money, so we're stuck with blood on the private healthcare insurance.
Okay. So here are some things to think about. The timeline: sudden versus gradual, episodic versus constant, cyclic with or menses, links to sleep or over loss training. So these are some things to think about when you're thinking about histories and triggers. Anxiety phenotype, panic waves versus baseline, palpitations, tremors, sweating, constipation, diarrhea, heat intolerance, insomnia, also cold intolerance, which is what she had. Rashes, so itching, rashes, is it caused by heat, exercise, or showers, or is it caused by cold? hives, dermographism, flushing, angioedema, GI symptoms with flares. So these are all things that to sort of flesh out. Acne, what's the distribution? Is it in her jawline, or is it on her trunk? Is it on her face? Hirsutism, too much hair or hair loss. Did their cycles become irregular, or did they change? Are they regular and change? And has she had a change in weight of more than 5% over the last 2 months before she saw you? Any cravings, particularly salt and sugar, which are associated with cortisol or stress hormone abnormalities? And are there any reactives like blood sugar droppings, lows? Infections, antibiotics, medications can cause it. Mold, a change in environment. The family, did the family move from Wilkes-Barre, Pennsylvania to Las Vegas? And in her senior year of high school, and she missed out on all, missed her friends and her proms and all of that.
It's Reno that's the culprit. She went from Vegas to Reno.
Reno's the safe haven. Vegas is Sin City.
Right.
Too much caffeine, not enough, right? Not enough exercise. Too much exercise, over exercising can cause an excess in cortisol. Is she feeling, does she have a feeling of a safety, or is she in fear all the time? So these are all historic questions that you may want to ask. On a physical, is there a blood pressure or heart rate change from when she's sitting to standing, lying to sitting? Any types of tachycardia? Again, the acne morphology and distribution. Any excoriations? Is she scratching it and making where the itching, bleeding? Does she have any dark skin areas, or especially around skin folds, around the neck, the elbows, or the knees, the wrists, or the ankles? Those are glucose abnormality symptoms. Any tenderness in the neck, any nodes, any cervical nodes, any lymph nodes palpable under the arm, in the groin, and any tremors, hyperreflexia, slow reflexes. Slow reflexes can signify a thyroid, hypothyroidism, and strength training, so muscle training. And then dermographism. So you take usually take the back of a compression, or a hammer, and the thing you use for reflex hammer, and run it across the abdomen, the body, from the umbilicus to the top of the pubic bone. If it stays white for more than 20 seconds, that's usually a look at. That's called the Sargent's white line. It's a look at adrenal fatigue type symptoms. If there's any hair, especially in the pubic area, any hair inflammation, you may want to do a KOH stain. And then again, review of systems: dry eyes, dry mouth, any arthralgias, rashes, and photosensitivities. So these are some things to look at. Does anybody else have anything? I see there's a whole bunch of chat stuff. So Victor, why don't you monitor the chat here?
Okay.
And,
well, they're participating in a silent
yeah, okay.
way.
So Dr. Smith has adrenal abnormalities for a lot of this, migrating rashes, parasites. Okay, that's good. PCOS, Dr. Antoli, and then genetic testing for metabolic pathways. And Genomind, is that a company? Is that a type of test?
It's a company.
Yeah. Okay. All
They
right.
do the test for the metabolic pathways, and they focus on the psych meds.
Okay. All right. So hold that in mind, because I'm not familiar with that. I don't know how many on here are. So you can expound on that a little bit. I don't know if you have any samples of anything you can.
Yeah.
Okay. So
they were the first company that was approved by the FDA to use the human genome to test for treatments and they focused on the psych meds.
Mm-hmm.
So I've used a lot. It's there's a very strong link between the results and the clinical experience of the patient.
Mm-hmm.
So
Okay.
it's General Mind is the one that I've been using. That's the original one.
Okay, so what I want you to do is add in some of these other things that we didn't do, and to get a more complete picture. Too much estrogen can cause her to be I guess, sympathetic tone. Also, cystic acne. Probably low estrogen because of her athletic history, and acne because of PCOS. Okay, Little Sin City. Okay. Definitely low progesterone, which is parasympathetic, especially if she's not ovulating. Okay, so all right, guys
I
are
think
on.
everyone's on it, Bill.
Okay.
We got to move forward. Get
All right.
get to the meat.
Okay, all right. So some physical findings, and these are pretty typical of androgen excess. So hirsutism, she has some excess growth on her chin, her cheeks, her lower abdomen, and one place you might not think is excess hair, but in the low back area, is usually that's usually a clue. If they have hair there, but not excess hair anybody place else, that's a clue that there's excess. There's the androgens are too high.
Yeah.
Virilization, enlargement of the clitoris, ingression of breast development, and then skin issues, cystic acne with oily skin, which is not typical of adolescent acne. And remember, this was age 18, and we didn't see her till age 25. So sudden onset of acne, hirsutism, breast regression, when your primary preferential diagnosis, you should all have this, right? But what should we look at first? Should we look at the psychiatric trauma, anxiety and panic attacks? Should we investigate our endocrine system? The virilization demands a hormonal workup, or should we do both? And did the trauma trigger the endocrine dysfunction? So what say you?
On chat, they're saying endocrine, it's PCOS.
Okay. Yeah, I mean,
And both.
So
They're
it's
saying look
fairly,
at both.
yeah, it's fairly obvious what we're dealing with here.
Mhm.
But a lot, especially when she's 18 years old, and experiencing these things, and the first thought is you're going to go see someone, and they're going to give you a pill and fix it. And as we know that life doesn't work that way.
Correct.
So somebody already asked, what is her menstrual history? Oligomenorrhea or amenorrhea it deals with is a first clue to ovulatory dysfunction. Insulin resistance, they look for those darkening in the skin folds, acanthosis nigrans, also skin tags, and central adiposity. These are metabolic red flags. When we're going to do our androgen panel, we're going to get a total and free testosterone, sex hormone binding globulin, DHEA sulfated, not just DHEA. You can get a dihydrotestosterone. The serum levels I find aren't very helpful, even if they're high. They don't really correlate with any symptoms, and I doubt that it's going to give us much information here. If we want to quantify the androgen excess, there's a number of ways to do it. The bioactive testosterone is probably the most accurate way. You need the testosterone, total testosterone, free testosterone, sex hormone binding globulin, albumin. Yeah, that's it. That's it. The problem that I have with the bioactive is that I really need a computer program to calculate it for me. And I like to be able to do things on the fly that I can do in my head, or at least on a piece of paper or with a calculator. So the free androgen index is probably a little less accurate than the bioactive formula, but I can do this one pretty much in my head. And the formula is you take the total testosterone divided by 0.288 times the sex hormone binding globulin. That'll even up the numbers. That'll give us the same the numbers in the same fold. So for males, 30 to 130 is considered normal, and about 50 to 115 is optimal. For females, about 0.9 to 6.0 is normal, but we wanted about 2% to 4.2%. And that's where the patients will be feeling good. And that's our optimal. I'm going to look at weight distribution. And we're going to document weight changes and fat distribution patterns. If you have a one of those some sort of a way to measure it, it's a good idea to try and keep track of it. You want to keep track of as much information as you can, because the patients do get exacerbated, because it's this is not a quick fix, and it can be a lifelong problem, especially when they're younger. They don't really have the patience for it. So we want to be able to show them that even if there are setbacks, that they are improving. Okay, so truncal obesity suggests metabolic syndrome. Okay, so the Rotterdam criteria for polycystic ovaries. Since you all guessed that, this was reformulated in 2023, and it consists of three entities: ovulatory dysfunction, so oligo-ovulation or anovulation with irregular or absent menstrual cycles. Number 2 is androgen excess. Clinical signs are hirsutism, acne on the face, skin breakouts on the neck and shoulders, pins and needles, peripheral neuropathy symptoms in the hands and feet, swelling of the hands and feet, elevated, increasing blood pressures, redness in the face. These are all symptoms of androgen excess. And then polycystic ovaries. So the ovaries have to have, depending on who you read, the Rotterdam criteria says you have to have 12 follicles in either ovary. So 1 or 2 is actually considered normal, but now at one point I've seen 8. But the strict criteria is 12 follicles. So, 2 of these 3 are sort of, one of them, ovulatory dysfunction. You're going to have to, have the patient tell us, or did their periods stop, for how long, and if have their or their periods, scant or almost non-existent. Obviously, if they have hair where it doesn't belong, or acne, or their blood pressures are rising, that's fairly obvious. And then polycystic ovaries, we're going to have to get an ultrasound one for that, or laparoscopy if it's bad enough. So again, I like to be able to do things sort of on the fly. And again, when you start seeing some of these patients, you'll start appreciating some of the patterns that you're going to see. So, here are lots of organs, and androgen excess in polycystic ovaries. And you can have any or all of these issues. So we can have anxiety and depression, irritability, moodiness, anger. You can have GI symptoms. You can have a decreased gut diversity, dysbiosis. You can have an increase in iron transport from cells. You can have a I actually did this for the American Academy of Medical Acupuncture, and we came up with what they call a yang deficiency, which is an energy deficiency. And I actually came up with treatment protocols for all of the hormones using acupuncture needle formulas. Increased abdominal pain, irritable bowel syndrome. Remember, high testosterone will metabolize, aromatize to estrogen. So you're going to end up with excess estrogen and all of the issues that one deals with estrogen excess and central obesity. You're going to have anovulation, oligoovulation, and it's going to affect the patient's fertility. You would think with excess estrogen and testosterone, you would have increased bone density, but actually what happens is that there's a saturation point, and there's a point where the opposite happens, and they end up with thinning of the bone and osteoporosis. It's again, too much testosterone, too much estrogen. They end up with insulin resistance, renal calculi, chronic kidney disease, erythropoiesis. They'll get an increase in hematocrit, and they're going to have an increase in pro-inflammatory cytokines, TNF alpha, interleukin 1B, and interleukin 6. So we see all of these things with elevated with the symptoms that we're looking at. So Grok can do the calculations in a flash. I'm still not into that, as a reflex. So we'll try it. So remember, we said that you're going to see symptoms of excess testosterone, and testosterone aromatizes into estrogen, and now we're going to see estrogen dominance. And so we're going to see, again, depression, cognitive decline, moodiness, sleep disturbance. We're going to have even more cytokine excess pro-inflammatory cytokines, including TNF alpha, interleukin 6, interleukin 17, and interferon gamma. Increased, again, insulin resistance, increased sodium absorption with water retention and edema. Again, bone remodeling. We get an oversuppression of bone turnover with osteosclerosis, uterine hyperplasia, too much estrogen. Estrogen causes cysts, ovarian cysts, breast cysts, uterine cysts. We call fibroids, endometriosis, which are technically cysts on the lining of the endometrium, and excess bleeding, menorrhagia they'll have. Visceral fat accumulates, constipation, inflammatory bowel disease, autoimmune tendencies, lupus, Hashimoto's, and Graves' disease. So we're going to see all of these things with excess androgens leading to excess estrogens. Insulin resistance in polycystic ovaries, again, depression, neuropathy, cognitive changes, loss of executive function. Remember, loss of executive function in the hormone world is a growth hormone deficiency. So you see how one entity begets the next one, begets the next one. Again, the skin darkening folds, acanthosis nigrans, inflammatory lung disease, an inverse correlate with the FEV1, FVC percent with insulin resistance, increased gluconeogenesis, elevated blood sugars, fatty infiltration of the liver, urinary frequency, renal insufficiency, testosterone and estrogen dominance with a decreased sex hormone binding globulin, increased thirst, hunger, increased visceral fat, visual changes, endothelial dysfunction, tachycardia, decreased HDL cholesterol, increased triglycerides, and overall fatigue. So here's our conventional diagnosis, and those of you that sometimes dealt with some of the specialists, especially the endocrine specialists, if you back them into a corner and say, well, what about A, B, C, and D? The answer usually that I get from them, any endocrinologist in the group here, I shouldn't say this. The answer I get is, I'm a board certified endocrinologist, that's why. So, because I said so. So our Serena went to see a gynecologist and an endocrinologist at age 19. The endocrinologist told her that she had elevated testosterone due to an atypical form of polycystic ovarian syndrome. So they prescribed birth control pills to suppress ovarian androgen production, and spironolactone, which is a potassium-sparing diuretic, which does have properties that blocks androgen receptors. It actually is kind of unique. It blocks the side effects of testosterone without blocking the useful, the reason that we would want to use testosterone. We frequently use this in older folks. If they have side effects, especially females, in our perimenopausal and postmenopausal females, if we're treating them with testosterone and they get some of the side effects. Spironolactone is very effective at blocking the side effects while leaving the positive effects free.
Hey, Bill, can I just add one thing? Is that
Yep.
I think I fell into the same trap that the endocrinologist did, and that is this young woman is very kind of petite and doesn't manifest the typical way that I learned PCOS when I was in medical school and family practice training, with like insulin resistance, like as a must see type of thing, because she really didn't manifest that at all. And she wasn't, developing the belly fat and the,
well, again, you're right, but
and so that's kind of one thing that I think I had to get my mind out of my traditional training and try to start thinking out of the box, because she didn't fit the picture from just looking at her labs initially when she was much younger, even especially.
Well, that wouldn't be any fun. I mean, right? They wouldn't need us.
Yeah,
right?
Exactly.
All right. So the conventional approach targets the symptoms, right? We're going to look at acne, we're going to look at hirsutism, and we're going to give you something to get rid of it, and irregular cycles. But what about the triggering events? What about our lifestyle? What about any of our metabolic or immune issues? Basically, they're told nothing can be done about them. So, this is where we come in. So again, this conventional treatment mechanics: spironolactone blocks androgen receptors, reduces oily skin, acne, and hirsutism, and it works fairly well. Usually, we start at anywhere at 25 milligrams and you can go up to 200. Usually 50 is enough, and like I said, it does work quite well. There are over-the-counter remedies that you can use that will suppress the androgen receptors also. Oral contraceptives can suppress ovarian androgen production, but it can cause side effects. It can wreak havoc with their cycle. And there's basically, it's a side effect city. I mean, there's lots of problems with it, and not only in the immediate time frame, but now we've been dealing with birth control pills and its aftermath for 60 some years, and we see a lot of gynecological pathology from having used synthetic hormones for long periods of time. Potentials for metabolic worsening, nutrient depletion, and masking root causes. Okay, so at age 19, if the oral contraceptives cause excessive weight and truncal fat deposition, does this consider the treatment successful? Is that a yay or a nay?
It wasn't successful.
No, it wasn't. So let me go back here. I got something there. No, she didn't do well at all. And over here on the right here, this is a normal ovary. You can see there's a couple of follicles. This is polycystic ovaries. They call it a string of pearls. It's almost like wearing a string of pearls. This is over here. And you can count them: 1, 2, 3, 4, 5, 6, 7, 9, 10, 11, 12, 13, 14, 15, 16, I 17, 18. I count 18 here. Just in this little loop right there. All right. Birth control pills they're going to mask ovulatory dysfunction. If somebody comes in and says, "Well, I get 2 periods a year," we're not doing. Again, we weren't made that way. We're supposed to have one every month. Every 28 days. We're really just sort of kicking the can down the road. Birth control pills can increase nutrient depletion. They can cause dysbiosis, especially B vitamins that are critical for methylation and energy. Birth control pills can a lot of times worsen insulin resistance and weight gain, the metabolic drivers of PCOS. So I'm not a big fan. Let's see, what do we have here? And menopause is similar to PCOS in a lot of ways, yes. So let's. Okay, so next question. What would you do differently? Option A, continue the birth control pills and spironolactone. This is the standard of care. How about adding insulin sensitizing agents? And the usual one is metformin to address root metabolic causes. And or berberine is a over-the-counter insulin sensitizer. It also has some activity against it.
It's a consensus on C, I would believe.
Well, that's our consensus, but let's pretend we're at the American Osteopathic Association School of White Bread Medicine, and
Right.
you're not allowed to step outside the box.
Yeah.
Okay.
Also, the testing obviously has to kind of be
Right.
continual. You have to kind of continue to
I
monitor.
can't tell you how many patients have come to me and said they went to an endocrinologist and they gave them this, they gave them that. I said, I asked about diet, doesn't matter. I asked about exercise, doesn't matter. Hopefully things are changing. I have two of my students that I've had now are actually in endocrinology residencies. So hopefully it's starting to change a little bit. One other thing about so we see a lot of patients with polycystic ovary syndrome, and metformin for blood sugar control is sort of the standard of care there. And I have to tell you that almost universally, if by the time they call us, I don't know exactly what it is, but these patients hate metformin, and they'll actually tell the front office person, if he's going to prescribe me metformin, I'm not coming in. Or when they come in, it's one of the first things that'll tell me, if you're going to write for metformin, I'm leaving. I don't know exactly what the issue is, but I've seen this dozens of times. So be very wary. There's some sort of something happens with these patients when they're on metformin. And if any of you have any idea, let me know. And let the group know. So what do we have?
Doctor, last time when we had the OBG doctor, he said that it causes also mitochondrial dysfunction, the metformin.
Okay. Somebody else said diarrhea.
Oh yeah, diarrhea, lactic acidosis, and lactic acidosis. That's why it's being discontinued if decreased kidney function. But Dr. David Sinclair, who's number one in anti-aging, he's recommending it as anti-aging. Also, metformin is given to produce ovulation. So it's given like clomiphene and metformin are given for women who cannot conceive to stimulate ovulation.
Yeah, so we like plain well, the books say Ceylon cinnamon. We've done as well with plain old store-bought cinnamon for insulin sensitization. Chromium picolinate is another one. Somebody put that in the chat. Berberine we use quite often. We like berberine for lots of reasons, and we use fairly high doses of it. For depending on which preparation you use, 400 to 500 milligrams, 2 of them twice a day. You can get a decrease in hemoglobin A1C within 6 months of 1%, which is what you get with metformin without the side effects, and you also get an improvement in your total cholesterol and HDL cholesterol levels also with berberine.
Wow.
We also use berberine in those doses with, I'm going to give you a little caveat, with resveratrol, 100 milligrams of resveratrol, after our weight loss programs, when the patients are done, with their GLP-1s or whatever they're doing. So the berberine and resveratrol is very effective at helping them not regain the weight. So that's again, one of the bonuses that we have that a lot of other folks don't.
Wow.
Obviously, on the right, natural androgen blockers, lifestyle and dietary intervention, is always part of the program. Okay. So oral contraceptives, they kind of work cosmetically. They don't have any effect on the underlying. They actually hide the underlying metabolism. Outcomes seem to be worse with weight control. With weight, it increases central adiposity. You're going to get an increase in triglycerides. We're going to get variations in the LDL-HDL ratio. You're going to get some neutral to increased insulin resistance. Your biomarkers that you want to look at is your waist circumference, blood pressure, hemoglobin A1C, insulin resistance, HOMA resistance. Again, you can do that as a calculation. I can give you a simple formula: fasting blood sugar times fasting insulin divided by 405. That'll get our units in sync. Our goal is less than 1.9, that ratio. Normal is less than 2.9. And we do this, pretty much for every patient, for every visit. And then you can follow the insulin resistance because there's a lot of moving parts. You got fasting blood sugars, you got random blood sugars, you got hemoglobin A1C, you got insulin levels. You can follow this HOMA-IR, and again, you can calculate this just with a calculator, and follow it along. Are they getting better? Or are they getting worse? And you can show the patients, they have a fasting blood sugar of 80 and a hemoglobin A1C of 5.8, which is in the pre-diabetes range, where Dr. Nario's cancer doctors say there is no such thing as pre-diabetes, and an insulin of 15, which is normal, and they're going to have a high insulin resistance. And then also triglycerides HDL ratio. Okay, so where birth control pills shine, you get more predictable withdrawal bleeding. You get some endometrial protection when the patients are anovulatory. We can improve the acne and hirsutism with ovarian suppression. You'll get an increase in sex hormone binding globulin and decrease in free androgens with birth control pills. You do get contraception, of course, and you get ovarian suppression, which reduces functional ovarian cyst formation. But there's always a but. Insulin resistance. These are not insulin sensitizers. You're going to end up with metabolic syndrome that needs to be looked at separately. You're going to end up with visceral adiposity. They're going to gain weight, especially in the middle. It can be worse, it could be better, but you need to follow it. There are cardiometabolic risks with birth control pills. Lipids, blood pressure, glucose are often require management. And then we're not looking at the root causes. Are they sleeping? Are they stressed? Do they have underlying issues that have not been addressed, like our friend Serena here? Are they doing any type of exercise? And also the thyroid is also an issue at times. And so monitoring, we need to look at the lipids, we needed to look at the blood pressure, we needed to look at the weight and waist. These are patients on birth control pills. Remember, there's a risk of blood clots with them. Some patients will end up with mood and libido issues, and patients with migraines, those that smoke, those that are over 35, those that have blood clot histories, and severe hypertension. These are not ideal people for birth control pills. The type of pills there are, you've got your ethinyl estradiol. These are your equine estrogens. These are potent hepatic first pass substances. You get increased blood clots. You can get a rise in triglycerides and blood clotting signals. Now, progestins, now we're talking about synthetic progesterone. They can vary from androgenic to anti-androgenic, and we're going to see metabolic and mood effects. There's no protection from these from estrogen. In fact, it actually worsens like endometrial stripe and endometrial thickness. A large contraceptive database is available, but the long-term exposure is a trade-off, symptom control versus cardiometabolic monitoring. We really don't like birth control pills. They cause all sorts of havoc. Unfortunately, the natural hormones have not been shown to be effective with contraception. So we have to do something if the patients need contraception. Remember that if you're treating patients with estrogens, they have to have progesterone on board also. It lowers breast cancer and blood clot risk, and it lowers the risk of all of the maladies that you see with the synthetic estrogens. But keep in mind that they're not reliable for birth control. I just brought out a list here of different birth control pills that have been used with polycystic ovaries. If anybody wants this, just let me know, and we'll probably put it up on the website, and I can send it to you also. Okay, Victor, anything in the chat we want to talk about?
Not really.
Okay,
I think,
I have 9 here.
Reiterating things you said.
Okay. All right, so skipping ahead here from age 21 to 24. Remember, we didn't see her until age 25. She began with excessive fatigue and brain fog and was extremely tired. She started developing ocular migraines, a vascular component. The migraines were cyclical. They were more prominent in the first half of her cycle, and when her period began, in the mid cycle, in the luteal phase, they diminished. And then age 24, she started noticing hair thinning. Her nails started breaking, classic signs of thyroid and nutrient dysfunction. So we have a young gal with a lot of moving parts here, and she's not getting a whole lot of help. So what do we want to do here? She's now extremely tired. She doesn't matter how much she sleeps. Is this a polycystic ovary related, a comorbidity? And what labs do we want to do to sort of tease this out? So option A is polycystic ovary related fatigue. Remember, she's got excess testosterone, excess estrogen, and all of the downstream issues from that.
We have option D on the chat.
Option B, the thyroid dysfunction. We want a full thyroid panel. How about adrenal fatigue? Adrenal issues, cortisol, stress,
Yes.
or again D, all of the above. So one of my little side things that I've been doing is I've actually gone back to school a little bit, and I've been taking the Institute for Functional Medicine courses on the side, Dr. Nario, just so you think I'm not doing anything. And their approach now is to look at the adrenals first, and look at cortisol and stress hormones, because obviously all of these symptoms will manifest stress and inflammation in some manner or another. So their theory is we start with the adrenals, you then go to the thyroid, then you look at the sex organs. Now, in reality, we probably do them all at the same time. But if you need a hierarchy or order, that's the order you want to be in. So we're going to look at the adrenals first, the thyroid second, and the sex hormones third. What do we have in the chat there, Victor? I got a lot here, so I don't.
We're talking about NP thyroid, Armour thyroid,
right,
and low dose progesterone.
Okay. Copper IUD, but not easy for an nulliparous female. I got a yikes from Dr. Quinn. Dr. Antoli, which formula did you want again?
About insulin resistance.
But I didn't hear you.
Insulin resistance, you
Insulin
said,
resistance,
yeah.
fasting blood sugar times fasting insulin divided by 405.
Oh, thank you.
Normal is less than 2.9. Optimal is less than 1.9.
Thank you, Dr. Clearfield.
Okay, and Dr. Quinn says, remember I mentioned resveratrol. It needs to be taken with something like yogurt if you take it for better absorption. What you really need to do is there's two types of resveratrol. There's a cis and a trans. You want the trans resveratrol. That's 95% potent. So you want the trans resveratrols. Most of the resveratrol, if it doesn't say if you look on a box and it doesn't say, it's usually the cis. The cis is only about 5% resveratrol. You want trans resveratrol. And
Wow.
I guess we're still not CME. I have to give it a little disclosure. I don't anymore, but I used to write for a company called Longevinex. And Longevinex, their pilot or their premier product is trans resveratrol with vitamin D. And Dr. Halassa, if you're listening, it has cyclodextrin in it, and it was formulated in 2004. So cyclodextrin isn't anything new.
Wow. Amazing.
Okay, so believe it or not. So here's our full thyroid panel. TSH, free T3, free T4, reverse T3, the TPO, thyroid peroxidase antibodies, antithyroglobulin antibodies. We now doing a spot urine iodine. Thank you, Dr. Hartman. B12 and folic acid, vitamin D3, and ferritin. You have to do all of these. These are the nutrients that you're gonna find deficient. And we've been doing spot urine iodines. It's more accurate to do a 24-hour urine iodine, but the patients don't really like that. So if we find something positive, we do suggest it. We don't do very many of those, but that is more accurate. And then you can get all the halides, so you can get the bromide and fluoride levels also. But a spot urine iodine, we've been doing that, and you have to know how to interpret it. So a normal level is, and I don't remember off the top of my head the units, 100 to 199. That's normal. If it's low, under 100, then we're going to we actually, and even if they have autoimmune disease, we are going to recommend some iodine. 3 months down the road, if you repeat it and they are on iodine, if the patients are taking iodine, the spot urine iodine levels are going to be extremely high. It does not mean that they're overdosed. It does not mean they're poisoned. All it means is that they're using iodine in some form. And when I mean high, I've seen it as 1,000, 2,500. We had one patient at 13,000 on the spot urine iodine. And they had no symptoms or signs of iodine overdose. So all it means is low, normal, or using. And again, so the 13,000, we were a little bit worried about that. So we did do a 24-hour urine on that, and they were perfectly adequate. They were perfectly fine. The adrenal function. We like the reverse T3 as a screen for that for cortisol or stress hormone, and the reverse T3 over 15 they're usually symptomatic. Symptoms are when the patients wake up, they're tired. In the middle of the morning, they need something to keep them going. In the afternoon, they feel like they need a nap. By dinner time, they're exhausted. Later at night, 8, 9, 10 o'clock, they get a second wind. That's when they're most awake, and that's when they get their most work done, and that they're most alive. Then they have trouble sleeping, and there's usually sugar and salt cravings. So those are the symptoms that you're going to see. To be more direct, we get an AM and actually a PM cortisol, DHEA sulfated. DHEA and cortisol are inversely related to each other. So if the patient's cortisol levels are high, you can treat them with some DHEA, and it will balance out the cortisol. A 24-hour 4-point cortisol saliva test. I think I have a picture of one here. You've seen those where they show you the cortisol activating response, and then the cortisol levels fall off during the day. So 4-point cortisol level, we get it at awakening, around noon, around 4 o'clock, and then at bedtime. Other labs we do, the CBC with DIF, CMP, a lipid panel, fasting insulin, fasting glucose, hemoglobin A1C. I use IGF-1 as a screen for growth hormone. Homocysteine is a nutritional marker, and it also can also be a marker for damaged coronary artery disease or coronary arteries. Prolactin, and remember from Dr. Gordon, low prolactin levels, especially in traumatic brain injury, are indicative of chronic treatment-resistant anxiety and depression. And pregnenolone, that's our hormone of memory. The androgens, total and free testosterone. I don't, like I said before, I don't take much stock in DHT, the serum DHT levels, sex hormone binding globulin, DHEA sulfated. You want to reassess the androgen status on and off treatment, estradiol, LH and FSH, and PSA in men. And just a little hint, if you're coming to AMMG in April, I have some new groundbreaking information on FSH. That's pretty, that at least in my brain has been pretty exciting. And I found I heard a little blurb about this last December in Vegas at the A4M meeting. It was just someone said it something in passing, and I picked it up and ran with it. And it's not the whole lecture that I'm doing because it's laboratory part 2, but it was so interesting that I actually put it in there. So if we don't get to it, if we have an opening, maybe I'll bring it out on one of these hours also. Okay, there is a connection between polycystic ovaries and Hashimoto's thyroiditis. In the general population, 1 to 2% and up to 5 to 10% of women, depending on the geographic area and iodine uptake, have both polycystic ovaries and Hashimoto's thyroiditis. And so this is an example of, we have a gynecological problem and we have a thyroid problem, and never the two twain shall meet. Now, it's been estimated that almost up to 25% of females under the age of 25 have some form of polycystic ovary symptoms. Females with polycystic ovaries are 3 to 4 times more likely to have Hashimoto's than women who do not have polycystic ovaries, and the odds ratio is 3.27. So in other words, the odds of having an autoimmune thyroid disease and polycystic is 3 times higher with polycystic ovaries. The common etiologies are chronic inflammation, insulin resistance, and GI permeability and immune dysregulation. So keep that in mind, because when we look at autoimmune thyroid disease, these patients frequently have GI symptoms, immune dysregulation. And again, my stomach's killing me. Go see the gastroenterologist. He did a colonoscopy. I have an erosion, or I have an irritation, and they give him, Prilosec or whatever it is that they use, and never the twain shall meet. So at age 24, the patient stopped the birth control pills on her own. In November of 2025, she's decided there were too many side effects. Her menstruation ceased immediately, and remember that the hypothalamic pituitary ovarian axis had been suppressed with the birth control pills, and now it's shut off completely. And so she presented to us for some more insight. Some of the things that were found, and this is from Dr. Klausner himself: asymmetrical small breasts with poorly formed left nipple, evidence of androgen interference with breast development, some virilization, slightly enlarged clitoris, long-term androgen exposure can affect this. There was no obvious acne or facial hair, likely due to the residual spironolactone, previous suppression.
I think the facial hair is, she knows how to hide it. She plucks a lot, but she did have hair on the small of her back though, and a lot of leg hair too.
Mm-hmm. Okay. Anything in the chat? Anybody have any comments? Anything else here? Let's see. What else is new? We contacted Armour and asked about the use of corn in processing. Since over 90% of corn in the U.S. is GMO, the question was asked and not answered. Okay. I would like a copy of it too, the birth control pills. How about a hint? I don't hint about, I'm talking here, so I'm not sure. Let me know what it is you want to hint about. Okay. So let's take a look at the thyroid now. Why does it go on the fritz? When I give my thyroid lectures, this usually I start with this, especially like to Noma, the real doctors, the regular doctors. So the theory is that there's a failure to convert T4 to T3, and in the last couple of years, they've sort of squirmingly said, okay, well maybe some nutrients are not being absorbed also, and that's it. And there's no other way to look at it. So just a failure of T4 to T3. So why does T4 to T3 fail? Advanced age. And what is an advanced age? My granddaughter, when she was 3 years old, overheard her saying something about getting older. So I asked her how old was, and at 3 years old she told me 20. So how old is an advanced age? Too excess goitrogen consumption. So the foods that we tell patients that are good for them that nobody seems to like, and that are especially good for menopausal and menstrual symptoms. So your cruciferous vegetables, cauliflower, kale, broccoli, and then some things like spinach, strawberries, pears, certain nuts, all have what chemicals in them that are known as goitrogens. They slow the thyroid down. So the consensus is with the goitrogens, what we want to do is we want to have them cooked. You don't necessarily need to eliminate them, but the raw cruciferous vegetables will slow the thyroid down. Now, if you have a spinach salad, are you going to die? No. But, we have patients who come in here, they have a spinach salad every day for lunch. So if we can slow it down a little bit, we can get at least a little bit of traction. If they're on thyroid medication, they have to take the thyroid medication separate from everything else. They can't take thyroid medication with any other medication, vitamins, herbs, minerals, and they have to take it with just a couple of sips of water to get it down. Ideally, they should not have anything an hour before or an hour after they eat, an hour before or hour after they take the thyroid medication. And this doesn't matter if it's the synthetic levothyroxine or if it's the natural ones. The two natural ones, unless you compound it, are Armour and NP thyroid. Those are the only two that are left. And the FDA is trying to get rid of them, by the way, also. But they have to be taken separate from everything else. And I tell the patients, you can't use juice, you can't use coffee, you can't use tea. It has to be separate. And a lot of them, it's going to disrupt their day. So one of the questions that I asked them was, did they get up to go to the bathroom in the middle of the night? Those of us over age 50, that's fairly common. If they get up at the middle of the night, 4 o'clock, 5 o'clock in the morning, fairly regularly, we'll have them take the thyroid medication then. And then by the time they get up for the day, they're good to go. They can take it at night if they haven't eaten anything for an hour to an or so, also before they go to bed. But it has to be done at a consistent time. You don't want them to be taking it at 2 o'clock in the morning and then 5 o'clock in the morning and then at 10 o'clock in the morning. It has to be at a consistent time. Remember the lyothionines, the T3s, have very short half-lives. I think the half-life's about 3 to 4 hours. You have to dose them at least every 6 hours. So usually at least twice a day and sometimes 3 times a day. Birth control pills, as we've discussed, chemotherapy and radiation exposure, toxin exposure, extreme exercise, inflammation, any type of itis, low iron, low growth hormone, low testosterone, and these medications will interfere with T4 to T3, particularly amiodarone. Amiodarone is a fabulous medication for acute atrial fibrillation. Patient comes in the hospital in AFib, you give them, the cardiologist gives them IV amiodarone, and within a couple of hours, the atrial fibrillation is quieted down. The problem is that they'll then give the amiodarone to the patients to go home with in pill form. And that's where the trouble starts. I actually had a doctor who I covered with. He was a little bit, I was in my 40s probably then. He was about 60, and he had probably Hashimoto's thyroiditis, but we didn't know about it then. But he had a very fragile thyroid, and he would go and he started having cardiac condition. He'd go to the hospital. They give him the amiodarone. They would stop the atrial fibrillation. They'd send him home on the amiodarone, and within 2 weeks, he was having a full-blown hypothyroid crisis. Go back to the hospital, and they did the same thing over again. After about the third or fourth time, I said, "Tell the cardiologist to give you something else," and they wouldn't. So, after a while, I said, "Don't take it. So tell them you're taking it and don't take it. We'll give them something else." Beta blockers is another one. Phentoin, Dilantin is again will interfere with thyroid. Prednisone and lithium. So these all of these here are an issue when it comes to interfering with thyroid and synthetic progesterone. Now, notice it's not the natural progesterone; it's the synthetics. So these are the 7 root causes, the 7 things you have to look at if you're going to treat thyroid disease. And this is where we shine. Patients come to us after they've been like this lady, 7 years of getting nowhere. And we're going to look at her immune system, gastrointestinal tract. We're going to look for heavy metals. We're going to look at some infections. And the infections that we're going to look specifically for, Epstein-Barr is probably number 1 cause. So if she had, mono when she was 18, that's a key. That's a key right there. That's a trigger. H. pylori is another one. That's probably number 2. And we like seeing patients with H. pylori because we've actually on a few occasions, not too often, but on a few occasions, we've gone back, treated the H. pylori, and the autoimmune thyroid disease disappeared also. Probably about 15% of the time, but but enough to take notice. Hepatitis, herpes, Lyme disease, and Yersinia, which is food poisoning. Those are the infections you want to look at. The HPA axis. So this is again your cortisol. Stress hormone levels. And again, we mentioned iodine. So iodine, fluoride, bromine. I don't have time, or I've been talking for a while about going into the the whole iodine, the story of iodine. But look that up. Look up the story of iodine and fluoride. It should be fluoride, not fluorine. So look up that story. It's pretty interesting, and it's another one of those medical follies, sort of like the low-fat diet, where we thought we knew better, and we shot ourselves in the foot. And then again, the medications that we talked about. So molecular mimicry. This is where items like gluten that you get in wheat or casein, which is in dairy, they have similar chemical characteristics to the thyroid molecule. And we get what a cross-reactivity occurs, and the immune system misidentifies these foreign substances as thyroid substrate. And eventually, it realizes that it's not, and it triggers an immune response. The body attacks the thyroid as its own. And the inflammatory cytokines that are developed from gluten and casein are Th17, interleukin 6, 15, 17, and 22 and 23. So this is a clue about what we can do to try to overcome, some of these issues. What is potent against the Th17s? What treats interleukin 6? What treats interleukin 15, 17, 22, and 23? That's going to be your homework assignment. I'm not going to tell you what it is. This chart is what I use to distinguish ourselves from the white bread, medical doctors. So the conventional model is over there in the yellow, a failure to convert T4 to T3. Our diagnosis, we're going to do a TSH. Lately, they've been reflexing to T4. No other diagnostics are necessary. The remedy, levothyroxine, that's it, and diet doesn't matter. Well, of course, we do everything that's on the right and get criticized for it for spending too much money. But we're the ones who actually take these patients and turn them around. And so you're going to look at gluten, you're going to look at toxins, you're going to look at infections, you're going to look at the cortisol HPA axis. We measure iodine, and we're not afraid of iodine, and we look at the patient's medications. There's the labs that we do. We talked about them again. And some of the other tests that I didn't mention, the functional GI evaluation. So I like the GI map. I know Genova has one that's a little bit more sophisticated, but the GI map tells me pretty much everything I need to know. If we got nowhere with whatever comes out of the GI map, we'll look at SIBO, so small intestinal bacterial overgrowth. We will do micronutrient testing. If you do the Dutch test, you'll get that in there with that organic acids. You'll get the main micronutrients. We do heavy metal testing. I do a hair follicle test as a screening. That seems to at least weed out. So if the hair follicle looks pretty good, it's probably not heavy metal. I mean, it's not 100%, but it's pretty good. One caveat though, every patient that I've done a heavy metal hair test on in the Reno area is positive, highly positive for uranium. I'm not really sure what to do about it. But it seems like it's just endemic in here. I know we were downwind from when they used to do nuclear testing in the 50s, so I hope they don't bring it back. Bacterial cultures, of course, C-reactive protein is inflammatory marker, our hormone evaluation, spot urine or 24-hour urine iodine. The remedies, levothyroxine, according to the endocrinologist, that's the only thing you can do. We've done T3 only, T3, T4 combinations. Desiccated thyroid. We like for the thyroid, when the patients have positive thyroid antibodies, we use the plant sterolins, particularly Moducare is the brand. I can mention the brand. We've also used something called Wobazyme N, which is an enzyme. It's not quite as potent, but Moducare can get to be a little bit pricey. Wobazyme N is about 1/3 the price. And we use a lot of low-dose naltrexone. Gluten-free diet, low goitrogen diet. We eliminate food sensitivities. We'll do a food sensitivity test. And just in general, white flour, white sugar, dairy, soy, and corn. Those are the bad guys. So that's sort of just a general overview. This is a patient's profile here. Her hemoglobin A1C was 5.4. Her insulin was 4.6. Her vitamin D was at 56, which isn't terrible. The midpoint is 65. But her ferritin level, her iron store, was extremely low at 9. Our goal here is 90 to 110. Iron deficiency alone can cause fatigue, brain fog, hair loss, and impaired thyroid function. So you need to check the ferritin level. You need to check B12 and folic acid and vitamin D. Her androgen panel. Hey, Victor, did you want to present this part?
No, it's okay. I shared my slides on the chat so people could look at them.
Okay.
So it's just that's kind of the main thing I wanted to talk about, but we can do it some other time. Don't worry about it.
Okay. So
this is all good.
She had a total testosterone of 98. 30 to 40 is about our sweet spot. That's where we want to be. 98 is, more than two and a half times where we want it. She had a very high free testosterone. The DHEA is at 265. That's not terribly high. 200 to 250 is usually considered adequate. And sex hormone binding globulin, that's the protein that binds testosterone that we use as it travels in the bloodstream to get to the organs to where it goes. So the free androgen index is 98 divided by the product of 48 times 0.288. So if somebody can do that math, yeah, 98 divided by the product of 0.288 times 48. So her TSH was 3.1. Remember, 0.4 to 4.5 is normal. Our goal is 0.8 to 2.0. And remember, TSH is an inverse. The higher the number is, remember, if you don't have enough, our brain tells us to make more. If we have too much, our brain tells us to make less. So the number that we get is an inverse. So the midpoint is about 2.0 to 2.5, 2.2. 3.1 is normal, but in the low normal range. Free T3, this is the part that does the work. This is, is the thyroid getting to the tissues? 2.0 to 4.2 is considered normal. Our goal is about 3.4 to 3.6 to 4.2. So this is sort of low mid-range. We're pretty close to where we want to be. So she's getting, some thyroid molecule there. And the free T4 is our store unit. This is on the lower end of normal. We wrote that about 1.1 to 1.5. So again, free T3, free T4, they're normal, but on the lower end of normal. And the TSH is also on the lower end of normal. And somebody looking at this pattern here, well, they'll do a TSH at 3.1, you're fine, even though she has all the symptoms. But let's look at the antibodies. So now you have to look, first thing you need to look at it with the antibodies is whichever lab you're using, you have to look at their scale. LabCorp has a different scale than Quest. Quest and Renown, so the biggest hospital chain in our area uses the Quest scale. So normal for LabCorp is 34 with an optimal of 20, but normal on Quest is 9. So if you get a 17 and the patient's got it using Quest laboratory, that's high. If you use 17 on the LabCorp, that's not high. So again, you need to look at what your calibrations are, and you need to mark it in the chart, because if over time the patients will go from one to the other, and if you don't know, if they have 17 today and they have 17 today from LabCorp, and they had 17 2 years ago, but it was Quest, they went from high to normal. So you need to tease that out. And her antithyroid antibodies, normal in the Quest scale is less than 1.0, and in the LabCorp scale, it's less than 4.0. So she's at 21. So she's 5 times normal in the antithyroid antibodies, and she's about 4 times normal with the TPO thyroid antibodies. We jump on these if they're positive by 1 point. You don't want your patients, if you find that they have the immune issues, you don't want them to develop a full-blown autoimmune thyroid disease. It's a miserable existence, and what happens is that lymphocytes replace the normal thyroid tissue, and that's scar tissue. You can't unring that bell. So if we find autoimmune antibodies at age 25 at a low level, we jump on it right away, because if you come back 5 years later and don't do anything about it, this 144 is going to be 644. And at that point, we're pretty much stuck. So, like I said, it's 7 times over the optimal level, and we even though the thyroid function is normal. So Hashimoto's thyroiditis is your immune system has been triggered and your thyroid function is low. Graves' disease is your immune system has been functioned and your thyroid function is high. So they're sort of the polar opposites of each other, although there's a bit of a different pathophysiology in the background. But we emphasize the Hashimoto's thyroiditis because it is the most prominent. 98% of the thyroid issues that you're going to deal with are hypothyroid, low thyroid, and almost all of the by the time someone gets to see someone like us, almost all of it is going to be hypothyroid from your immune system. So I tell the patients, it has an exotic name for us, Hashimoto's, because it was discovered by a Dr. Hashimoto in Japan in 1912. If it's hyperthyroid, it's Graves' disease, discovered by Dr. Graves. I'm just sorry that Dr. Nario didn't get there first, so it would be Nario's disease, or Dr. Burgess. So there's 5 phases. Phase 1 is a genetic predisposition and triggers like Epstein-Barr, gluten, and the thyroid function is normal, and the antibodies are normal. And the first symptom is anxiety, an unexplained anxiety that comes on over several days to several weeks and lingers. It is not alleviated by our usual anti-anxiety agents, particularly the benzos. And remember, our patient, when we started, what was the first thing that she started complaining about? She complained that she had, all of a sudden, age 18, she started having anxiety. Phase 2, this is when the immune infiltration begins. The antibodies are now positive, but the thyroid function is normal. So you'll see this quite often. And, thyroid function is normal. You'll see a TSH of 2.4, 2.6, even 3.1. And the patients, that's all that's looked at. The patients are told that they're normal, even though they have all of the symptoms of thyroid, autoimmune thyroid disease. The lymphocytic infiltration has begun, and you can see it on an ultrasound. Phase 3 is a overt hypothyroidism. The patient will have a high TSH, a low to normal free T3 and T4. Phase 4, the immune system is taken over. There's usually other autoimmune issues, particularly in the GI tract and also in the eyes. They get dry eyes or Sjogren's disease. And stage 5 is burnout, and the thyroid basically is non-functional. So those are the 5 phases. Most of the patients you're going to see, they'll show up in phase 2. And if we can turn the clock back and turn the antibodies back to normal, that's you're doing your patients a huge service. And don't listen to it's TSH or nothing, and it's levothyroxine or nothing, and diet doesn't matter. Those are not true. And there's nothing you can do about the thyroid antibodies. Those aren't true. If any of you are really interested in thyroid function and thyroid disease, one of the websites that I actually sort of subscribe to is something called UK Thyroid. So UK Thyroid is out of Great Britain, and it's patients basically writing in about their thyroid issues, and it'll make your hair stand on end. I mean, it's just one after another after another. They have a national health service there, so they're only allowed to do certain things. And the GPs don't know anything. The endocrinologists will only look at TSH. They have to go to private clinics, to get a free T3 done. I don't see any of them. I don't write, and I used to write in and give some advice for a while, but it got to be too overwhelming. I mean, I could spend 12 hours a day doing that. I don't see anything there about low dose naltrexone. I don't see anything there about diet, really. I don't see anything there about immune modulators. Nothing. So I get it as in an email every morning, and I usually read one or two of them. But if you want to see the scope, really see the scope of it, look at something like that. It's called UK Thyroid. So what are we going to do here? The TSH is 3.1, which is normal. The TPO is 144. Most of your conventional doctors won't even look at this. They won't even know that this is a problem. And how would you interpret these results? What would you do next? So anybody want to chime in?
Plant sterilants, maybe.
Yeah, that's what we're going to do. So who wants to just stick with the TSH? And we'll monitor it. I mean, it's normal, right? We're going to monitor it. How about thyroid replacement? Would you use any type of thyroid replacement? Suppose she tells us that she's tired all day long and her skin is dry and her hair.
You could do a low dose of.
You do a low dose.
Nature thyroid.
Would you use levothyroxine, or would you use the combinations?
Armor, the combination.
We like the combinations, but your medical board is going to say, Dr. Antoli, you're a quack. You're not. You're using unstable medication. These are unstable. They're going to cause heart disease.
And it's going to be removed by the FDA.
Right? Yeah. That's coming also. Option C.
Desiccated.
Yeah. There used to be it hasn't been around since 2020. There used to be one called Nature Throid. And
Yeah,
Nature Throid had calcium and magnesium in it also.
Yeah, it's gone.
I know, yeah, it's gone. I know it's gone. But what's one of the side effects from levothyroxine? Patients that are on levothyroxine for 6 months, a year, 2 years. What's one of the side effects?
mm,
I
I
just
know
gave
that
you a hint. I just gave you a hint.
they always have to increase the dose. It's always suppressing the thyroid and they go up the dose.
Right.
Is
Well,
anxiety.
osteopenia, osteoporosis, right?
Yeah.
All right. Why is that? Is that really a side effect of the medication?
I think because they don't take the T3 or something. They don't take the combination.
What does the thyroid produce?
Parathyroid hormone, no, it affects it.
It does. Yeah. So
T1, T2, T3.
the thyroid produces T1, T2, T3, T4, and calcitonin.
Right.
Calcitonin stimulates calcium production. Side effect of synthroid, levothyroxine, and even the desiccated thyroids, osteopenia, osteoporosis. Well, is it really a side effect, or are we just not replacing the calcium that the thyroid stimulates? Think about it. Root causes first, the gut, the nutrients, and the toxins. And again, a combination. So obviously, we're going to do all of these things. So the point of all of this is that you can't just look at the thyroid and say the TSH is normal, go home. It just, I mean, it's done that way, and that's why the endocrinologists don't like us, because the patients come to us because they're not getting any answers. And then when they get better, they go back to the endocrinologist and they tell them, no, you're not any better. They don't know what the hell they're talking about. So there you go. Okay. It is 6:42, and I got 20 in it. 20. Anything in the chat to discuss?
No,
Huh?
no, I don't think so. I think everyone's been answering your questions.
Okay. So here's your normal range, 0.545 to 4.5. There's been some talk I've over the years that it shouldn't anything over 3.0 would be considered hypothyroid. Remember, it's an inverse. The 4.5 is low, the 4.45 is high. Our optimal, we really shoot for about 0.8 to 2.0. That's when the patients feel good. And there are risks in the TSH of various entities, in isolation of high cholesterol, hypertension, progression to overt hypothyroidism. Our patient is 3.1, and she's already, in that danger zone by our integrative standards. This is a chart. This actually, I think this came from Dr. Brownstein. I think it was in one of his books. And so I like to put this up so the patients can see, if TSH is 3.1, so she's here somewhere. And then the free T3, if this is here, it should be here. But if it's here, then we're really not converting. And if it's here, then then she's compensating. So this is sort of make a good visual. Okay. Autoimmune, understanding Hashimoto. So it's your immune system is triggered, and your thyroid is running low. We talked about the 5 phases already. I'm not going to go through them again. Laboratory findings, and we talked about the cortisol or stress hormone. Remember, I like to use the reverse T3 as a proxy for it. And cortisol, I think normal is 7 to 22. Here she's at 18. The reverse T3 is at 13. If they have symptoms, again, when they wake up in the morning, they're tired. In the middle of the morning, they need something to keep them going. In the afternoon, they need a nap. Dinner time, they're exhausted. Later at night, they get a second wind, and then they have trouble sleeping, and their sugar and salt cravings. Those are the symptoms. And if you ask those questions, you're going to find 30% of your patients are going to tell you, yeah, what are you looking in, hanging outside my bedroom window watching me? They're amazed that someone could actually come up, with sort of their lifestyle. Low stress and high cortisol increase the conversion of T4 to an inactive T3 instead of the active T3. This is kind of the brake pedal that slows metabolism. Remember that our patient here has psychological trauma, or the HPA axis is probably the key. So if we will dig deeper, and you see I got roots there. Nutrient deficiencies, GI permeability, heavy metal toxicity, adrenal insufficiency, the root causes of polycystic ovaries and Hashimoto's thyroiditis. And we talked about infections. I might have missed mold. There's another one, mold and mycotoxins. Halides, halide mimicry. So remember, iodine, fluoride, and bromide are all chemically similar, and then our medications. The GI function, our leaky gut. So remember, 80% of our immune cells live in the gut, particularly the small intestine. The leaky gut drives immune activation. Intestinal permeability allows toxins and food particles to enter the bloodstream, trigger the immune activation against the thyroid. And the most common cause is your standard American or SAD diet, chronic stress, food sensitivities, and I didn't even put on here, again, psychological trauma. Okay, the molecular mimicry of gluten, casein, and thyroid, we already covered that. The immune system is primed by the gut permeability. It misidentifies thyroid tissue as a foreign substance, attacks it along with the gluten and casein. Research demonstrates that increased intestinal permeability is a key factor in autoimmune thyroid development, with gut barrier dysfunction preceding autoimmune activation. So this is where she gets her rashes, her skin rashes. Heavy metal toxicity, mercury, phthalates, and endocrine disruptors, receptor blockers. Toxins that physically block thyroid receptors, creating a state of cellular hypothyroidism even when the blood levels are normal. So the blood levels are normal, but it's not getting to the tissues. If you're a sushi lover, be wary of mercury. Also dental fillings. Psychological trauma, adrenal burnout, where the body can no longer maintain the hormonal balance. Chronic cortisol elevation, sustained stress response depletes adrenal reserves over the years, and thyroid resistance. High cortisol desensitizes thyroid receptors and compounding the hypothyroid symptoms. So at this point, we've identified 7 root causes, and which order do you want to go in? And I know it's getting late, especially back home, back east. So again, we're going to look at the gut, gut first. Then we're going to look at nutrients. Then we're going to look at the adrenals. I know the IFM likes it the other way around. Then we're going to look at detox. Then we're going to look at infections, and then we're going to look at the halides. In reality, you're probably going to do most of these at the same time. Go by you prioritize what the patient's symptoms are. So here's our integrative protocol. We want to eliminate the triggers. So remember the bad guys, gluten, dairy, soy, corn, and sugar, the primary drivers of gut permeability and molecular mimicry. You're going to heal the gut. We're going to use bone broth, fermented vegetables. Budwig snack is a combination of usually cottage cheese and either olive oil or coconut oil, and you can put in some chia seeds with it also. This was developed by a Johanna Budwig, who was the Minister of Health in West Germany in the 1950s. You want to limit your goitrogens, again, 3 to 6 servings per week if you can, and they should be cooked. And remember, it's your cruciferous vegetables that are the main culprits here. Your gut healing program, your 4 R's. So you're going to remove the bad guys, caffeine, alcohol, and the bad guys that we already talked about. You want to repair them with clean whole foods. We're going to make sure you get some omega-3 fatty acids, so oily fishes, salmon, mackerel are the oily fishes. We're going to use some GI mucosal healing techniques. We're going to use some aloe vera. Some patients are okay with turmeric. Some patients will react to it. Evening primrose oil, L-glutamine. There are most of the Supplement companies will make a nice powder that has a lot of these in them. I'll give you mine since, again, I don't know what happened to the CMEs. So I like a GlutaShield from Orthomolecular. It has L-glutamine in it. It has DGL licorice in it, which is good for sort of upper GI and heartburn, peptic ulcer symptoms. It has some aloe vera in it, and it has those are the three main ingredients. Probiotics, fermented foods. I'm not a big fan of kimchi. I don't like it, but we like kombucha. And a plain yogurt, and then not the flavored ones and not the sugared ones, and then digestive enzymes and bile salts for digestion. So you can do a full elimination diet and start all four R's simultaneously. You can do it as a phased-in program, or you can start with some do a food sensitivity test, especially if they've been at it a long time, and sort of personalize the diet by looking at what the patients are sensitive to. She had a ferritin of 9, so we need to replace the iron. And this is low enough. I mean, if she is symptomatic enough, you may even want to think about some IV iron infusions for her to sort of get her up to speed more quickly. Selenium and iodine are your main ingredients that create the thyroid molecule, and they're crucial for the T4 to T3 conversion to happen. They also will reduce the thyroid peroxidase antibodies. Zinc and magnesium are 2 of the nutrients that will get depleted also with Hashimoto's thyroiditis. If you want to do measurements, though, you need to do the red blood cell measurements, not the serum measurements. The serum measurements really don't tell us much. You need red blood cell zinc, red blood cell magnesium. These support thyroid hormone production and improve insulin sensitivity. B12 folic acid levels, and again, the serum levels usually are, especially if they're taking a B complex, are usually fairly high. That doesn't tell the whole story. You need to look at the CBC and the differential. Look at the MCV, mean corpuscular volume. If the mean corpuscular volume normal is 79 to 97, if it's over 97, 98, 99, I've seen it as high as 105, those are big empty cells. That's a B12 folic acid deficiency with an MCV over 97. If the MCV is under 80, that's usually an iron deficiency. Usually, if we do replacement, we'll use methylated B vitamins. A lot of these patients will have a methylation defect also. And in vitamin D, 50 to 80 is usually our goal. Vitamin D will modulate a gut immune balance. For every 1,000 units of vitamin D3 replacement, the vitamin 25 hydroxy vitamin D level should go up by about 8 points. Okay, a ferritin of 9 is extremely dangerous. Iron deficiency will exacerbate the hypothyroidism. You need iron to distribute the T4 to T3. A low iron is a primary cause of failed thyroid. Optimal 90 to 110. At less than 40, the patients are going to have fatigue and hair loss, even if they don't have a frank anemia. Vitamin D will also help regulate gut immune function alongside it, and vitamin D will support and tighten those strengthen the tight junctions. Iron has 3 major forms: heme, which you'll get in meat, seafood, and poultry; non-heme, which is plant food and legumes; and inorganic, which is iron-fortified foods. We want to check your iron status. You can do a total iron binding capacity, transferrin saturation, ferritin, as we've seen before, hemoglobin. There's a genetic test for hemochromatosis for high ferritin levels. And so HFE is your hemochromatosis genetic marker. Blood iron levels can underestimate tissue iron levels by up to 10-fold. Remember, you want to look at So for blood iron levels, you want to look at MCH. That's also part of your differential, your CBC with differential. So the MCH is also a cell size. 27 to 33 is considered adequate. Anything under 27 or over 33 is usually an iron deficiency for both. For the MCV, anything less than 80 is an iron deficiency. The gold standard, of course, is liver biopsy. You can do an MRI for liver iron concentrations. Also, these are the RDAs for men and women, 8 milligrams a day for men, 19 to 50 years old women, 18 milligrams, a little bit older down to 8 milligrams, and you need 27 for pregnancy. So I just use that for reference for you. Hormone optimization, how are we doing on time here? Everybody hanging in there? We still good? Anybody still out there? Am I talking to myself?
We're good.
Bill, I
we're
have
good.
to go at
Yeah,
7.
yeah.
Huh? Am I talking to myself here?
No.
Okay.
But I wouldn't go past 7 though.
Okay, so we got 5 minutes. Should we do questions now? And what I'll do is we're on slide 67, Victor. We can pick it up, another time, maybe at the beginning.
Yeah,
We got
no
about
problem. I
15
gave
more
everyone my
So,
slides for
yeah,
my
so
presentation.
the idea was for you to jump in here. So you jump in here now, and I'll pick this up another time.
No, I mean, basically what I wanted to say is that I hope you guys downloaded my slides. I have mostly focused on orthopedic medicine for the past 25 years, and I'm traditionally trained osteopath in family practice, and I had very, I think, traditional training with endocrine and gynecological stuff, and Dr. Clearfield really pushed me to delve deeper into this, and I think I really enjoyed trying to kind of delve into the genomics of PCOS and Hashimoto's. And what you really see is that it's a polygenic, multiple allele type of syndrome, PCOS. So not everyone's the same. I mean, and that's clear with this patient. And that's what I saw, that she had one particular aspect of her PCOS was the hyperandrogen and typical high LH, low FSH, and the high cortisol. So the hormonal aspect of it was very clear, low vitamin D, and so things you could see were very obvious for her, but she didn't have the the hyperinsulinemia, the insulin resistance part of it. She's not obese, and so it's very interesting to see how the genomics manifest in a human being, and you could use this if you actually go through the testing and interpret it, use it as a pinpoint way to address your patient's issues, because the genomics are obvious and they're unique for each individual. And those slides kind of tell a big picture of how there's an overlap between the autoimmune thyroiditis and PCOS. It's really interesting to look at, and they're there for you to look at. I don't need to talk. I did my work for those slides. I learned a lot because of you, Bill, and I really appreciate you. And I'm sure everyone else does.
Well, I hope so. Anyway,
Wow.
so if not, we're going to pick on Dr. Quinn. Okay, so in the chat here, so Jeanette has 10 to 20 milligrams of lithium orotate may help, but remember, if we're talking about PCOS, remember, if we're talking about thyroid, remember lithium, even the lithium orotate was weaker than the prescription lithiums, can interfere with the conversion of T4 to T3. So we need to be a little bit careful with that. And then Steve says to take the thyroid medicine with LDN together, or we do use them in conjunction with each other. It's not that there's an interaction, but we recommend that the thyroid medication, when you take it by itself and not take it with the low dose anything else. So I'm not sure if you mean taking them together at the same time, or using them in conjunction. So I'm not sure about that. Dr. Nario, you have any thoughts on that?
I separate. I use LDN at night and then thyroid in the morning.
Yeah, I
So
mean,
it
that's what
has
I
to be
do. Yeah.
have to be separate.
Yeah. So I didn't mean it to you to interpret that we don't use, other entities, particularly low dose naltrexone, with thyroid medication. It's just that when they take them, we take them the thyroid by itself.
Though there are variations of LDN intakes now. It's not only at nighttime. I have patients who takes it also during the daytime, just because there are side effects like
Yeah.
vivid dreams. So
Yeah.
if they have that, the option to take it during the
Yeah. So
daytime can be
so
entertained.
So if you go by the LDN gurus, if that, so 10% of three major side effects from low dose naltrexone. One is insomnia. 10% of the patients have insomnia. You'll know about it pretty much right away. So what the LDN Trust recommends is that you back off every 2 hours, have them use it 2 hours before bedtime. If they're still awake, then 2 hours before that. Quite frankly, for me, that's too complicated. I just tell them to take it during the daytime. It's not sedating. It's not that you're giving it to them at night for them to help them sleep. What it does is it blocks the opioid receptors for about 6 to 8 hours, depending on the dose. While the opioid receptors are blocked, our body reacts by making beta endorphin. When the LDN wears off in say 8 hours, then our body, we're loaded up with the endorphins, and which is the most potent anti-inflammatory that we make naturally. The thought is that if you take it at night, by the time you wake up in the morning, you're ready for your day and you're loaded with beta endorphin. But like I said, 10% of the patients, it keeps them awake. Second side effect is some nausea that usually is not permanent. I've had maybe one or two patients. I've been using this stuff for 25 years, 30 years. One or two patients, not that I can think of, that it made them so ill that they stopped taking it. Since we've been using the GLP-1s, with our weight loss things, one of our recommendations is that we've been using either fresh or pickled ginger with the medication, with the GLP-1s, and that's done a tremendous job of cutting down on the GI side effects. It works quite nicely, especially with the mini doses. We we have less than 0.5% of patients have to stop because of the GI side effects. So we started recommending the ginger for those patients too, and it's for the LDN patients if they get nausea, and that seems to work out quite nicely. The third one I haven't quite worked out what to do about. The books call it vivid dreams. It's nightmares. About 20% of the patients get nightmares, and some of them can tell you some pretty wild stories. We've had a few patients, said that the nightmares are too terrible and they stop it, but not too many. Again, probably less than a handful, a dozen in 25 years. And LDN is my second line usually approach for the immune system. Number one is the plant sterolins, the Moducare. And just to let you know, if you think it's something exotic, somebody brought in something there's an over-the-counter cholesterol supplement called Cholestoff, which is pretty popular. I don't know if you've heard of that one, Dr. Nario?
No.
Cholestyramine.
Yeah,
It's cholestyramine.
Cholestoff is the same ingredients as Moducare. It's plant sterolins. It's
It's like a knockoff.
the exact same ingredients. No, it's been around for a long time. So
I think it's we call it cholestyramine.
cholestyramine is different. Cholestyramine is a binding agent.
Oh yeah, it's a binding agent. Yeah.
Yeah.
Oh, it's different. Okay.
How does prednisone affect a T3? Again, it will interfere with the conversion of T4 to T3. So yes, you'll get a lower T3 there. Dr. Cerna had already put that. So can I show the slide before conventional versus integrative thyroid? Let me finish these and I'll go back and find them, okay? Radon, I'm not sure what, there's a comment there. Dr. Klausner, okay, genomic approach. You shared the slides here, correct?
Mhm.
Make sure I get a copy of them, okay? I can't click
I
them.
sent it to you yesterday.
Oh, you sent them to me, okay. Spironolactone, how long to expect some improvement? We usually see pretty quickly, maybe 2 to 4 weeks. It works pretty quickly there. And good, there you go. Very comprehensive, good analysis, important information, Dr. Klausner. Thank you. Scarring of the thyroid. Remember, if you don't approach the immune system and the lymph cells take over, the thyroid is good as gone. Okay. For the slides, okay. There we go. Spironolactone, 2 to 4 months. I see it quicker. High reverse T3 can be indicative of toxicity as well. Yes, but 90% of the time it's a cortisol stress. Well, toxicity will have cortisol and stress also. 90% of the and I have a reference for you, Dr. Quinn, if you need that. Is cortisol is an abnormality. I avoid L-glutamine in anxious patients. They may be converting to glutamate, okay? Especially if cancer is involved. Did you test for homocysteine? Did we get homocysteine on her?
No.
Okay. All right. That was on the next set of labs. Okay. Could there be another
her
explanation?
her CBC was totally normal.
Yeah.
Right. So
yeah.
not...
Yeah. So sometimes you can get a hint on the homocysteine when you're looking at the MCV. If the MCV is large, that goes along with, a methylation issue. So if you don't have the homocysteine, you sometimes get a hint there. Could it be? Well, I mean, there could be lots of explanations of anxiety, but looking back, 7 years, and now she has a full-blown Hashimoto's thyroiditis. We can say, aha, that was the start. The trigger was probably her traumatic experience. So, and okay, I would probably start her with ILD oral potassium, low dose oral potassium or progesterone rather than cycled. But the problem with that is, we're going to end up with an abnormal cycle again. And one of the things we try to do is to sort of get her to become regular again. One thing that I mentioned in passing that is very effective in restoring menstrual cycles, not just for polycystic ovaries, but for pretty much any either anovulation, oligoovulation, as long as it's a functional thing. I mean, if they have cancers or something, that's another thing. But the myochiro-inositol, it has to be a 40-to-1 ratio, is quite effective in restarting the menstrual cycles.
I just haven't found that in practice. I've been able to give low dose oral progesterone to someone like her. So it gives her
When you say low
like
dose,
50 milligrams.
how much? 50?
50. And I might even make it SR.
Mm-hmm.
Gives them like a constant supply of progesterone, and they still will cycle. They'll start cycling more regularly.
What about using like 200 milligrams of progesterone for 10 days and then stopping it?
I mean, you can do it that way, but I think that the giving her low dose every day benefits her to have, a little bit of progesterone every day, which is myelinating. It's very calming.
Right.
Like we don't go from 0 to 50, right? We
No,
go,
I know.
we should be having a little bit of progesterone in our system all the time. So I find it that it's very comforting to them, and it doesn't interfere with their cycle. Can get it going again.
Okay. See, this is why I wanted to do this as a sort of an interactive thing.
Have you ever used the 50 milligrams and then tried to cycle like an extra 100 on 14 days, 14 through 28, something like that?
I mean, you could if you think she needs it, but yeah, you could definitely, I've definitely done that.
Mm-hmm.
You start with 50 and then you can decide, if you want to also add cycling in there,
Okay.
with a higher dose for 10 or 14 days.
Do you use it on the skin or oral?
I usually do oral because I want it to cross the blood-brain barrier, like for especially for a person like her with the anxiety.
Mhm.
And topical on the skin, it's not crossing the blood-brain barrier?
Correct. Put me on the.
Okay, and then Dr. Serta, you put in here about lithium and crime.
Yeah, there was a really interesting study in Texas when we were having this really crazy, violent crime problem. And they studied the water, and found it like absent of lithium.
Mhm.
And so it shouldn't be a problem here in Nevada because we've got lithium all over. There's a map on that link that I gave you. But if somebody uses reverse osmosis, which is lots of people here, it will remove the lithium. And so, and I don't know that you could test like a baseline lithium in somebody, like because I think what's optimal is a very low level,
Mhm.
but you could. And I do find it helps their
You know,
mood, especially in an area I know they don't
I
have
mean, we when they're using lithium for depression, which is much higher doses, and we do
much higher doses,
get lithium.
like 10 times at
Yeah.
least.
Mhm.
So it's another example of optimal versus, the therapeutic levels that people might give somebody.
Okay, and so Dr. Antoli says you put radon in the chat because in the Conference of Medical Excellence, hey, remember us? They said that in Nevada, the level of radon is very high. I thought that the level of uranium might be high because of radon. Or is it the other way around, the chicken and the egg? Is the radon high because of uranium, or is the uranium high because of the radon?
Uranium, it's high because of the radon, I think.
Well, it doesn't uranium become radon, right? And that's what we pick up in the detectors, like in the machines pick up radon.
Uh,
Yeah.
I'm not the radon expert here. I have to call Chris Kelly for that. So
Yeah, I think that's how it is. So
Hey, Bill, I have to get off. I'm just going to wish you guys a good night.
okay, thank you so much for
And
all
I'll
your
see you
help.
next week.
I hope I hope everybody, found this. It was a little bit different. I hope you found it interesting. Thank you. Thanks for participating. Thank you, Victor.
Of course.
I think we'll
yeah,
be back
thanks.
to a regular schedule next week. I'll put my slides online also, so you can have them. And Victor, you sent me those, so we'll put them both on there.
Okay.
Okay, and we'll have the video on. Anybody else have any I mean, I can stay on for a while. Anybody else have any comments or questions? And then
All
we'll
right. Good
find
night,
the time.
everyone.
I'll find the time, when to do the last, like, 15 minutes or so. I mean, unless you want us to hang on, and I'll do it now, but it's getting late, especially if you're back east.
She's in good hands.
I can stay. I mean,
I can stay.
You want me to
I
finish?
can wait either way.
Dr. Naria, what do you say? You're the co-host here.
No, go for it.
Okay.
They're demanding.
Okay.
We don't want a riot here.
Don't leave you hanging, huh?
Yeah, we don't want the chaos of the mob.
it's very interesting. It's and a lot of information, very important information.
Okay. So you heard what Dr. Cerna says. She uses low dose progesterone. I usually use it, the bioidentical. I'll usually start at 100 milligrams, and I'll use it on days 14 through 25 of the cycle. We've been doing this. I've been doing this for a long time. I'm going to give it some thought, though, Dr. Cerna, and maybe change my ways. But this is the way I've been doing it for now. The myochiro-inositol, and since we're not CME, I use ovasitol. It's a little bit of expensive, but if you can register with them as a practitioner, and your patients, if your patients, you give them the code, your patients will get a discount from them. There's other ones. Orthomolecular makes one. You have to make sure that it's a 40-to-1 ratio. That's the key, though, that it induces ovulation and improves insulin sensitivity. It's really quite effective. Thyroid replacement, we like the desiccated thyroids, the natural thyroids, over the synthetic T4s. Here's your conventional therapy. This is your conventional thyroid treatment. If the TSH is greater than 10, you give them Synthroid. If it's 4.5 to 10, if they have symptoms, you give them Synthroid. If it's under 4.5, they're crazy. Send them to the psychiatrist and tell them to go home. And if you're using anything other than this T4, levothyroxine, you're a quack. You're outside of medicine, by the way. So those are the official pronouncements. As of like 2022, 2023. I haven't looked at them recently. So desiccated thyroid, natural thyroid has T3 and T4 in it. Remember, those are the T4 is the storage hormone, T3 is the active hormone. We make it in a ratio of about 4-to-1, 78.2% T4 to 21.8% T3. The natural thyroids that are on the market, NP thyroid and Armour thyroid, have the T3 and T4 in that ratio. You can also rig it by using levothyroxine, and there's liothianine or Cytomel, and you can rig it. So Cytomel comes in 5 and 25 micrograms, and levothyroxine, comes in, I think, 12.5, 25, and then, all the way up to 200 or 300. So you can rig it, but physiologically, you want it about 4-to-1 ratio of T3 to T4. There have been some studies. I didn't put where the reference was. That showed better weight loss with the desiccated thyroid, better mood, better outcomes. Optimal dose was achieved when free T3 is in the upper third of the normal range. So we have our patient's now 25 years old. She has polycystic ovaries, Hashimoto's thyroiditis, a ferritin of 9. She's got amenorrhea. What are we going to do? We're going to use, again, so Dr. Cerna would use the progesterone 50 milligrams daily. I used 100 milligrams to start. I'll go up to 200 on days 14 through 25. We're going to start on our thyroid replacement. We're going to correct the ferritin and nutrients, and then add some thyroid support if indicated. So we're going to use I like iron bisglycinate. And we're going to use, usually they come in like 28 milligram capsules. We'll use 1 or 2 a day. B12 and folic acid if indicated, and vitamin D, myochiroinositol, and then add thyroid. So which one of these do you like, if any?
B.
B. B. If she has amenorrhea, I'll add in the myochiroinositol also. Okay. Lifestyle foundations for our polycystic ovaries. Protein meals first. Lower glycemic load, 25 to 35 grams a meal when feasible of carbohydrates. Make sure we get some resistance training 2 to 4 times a week, and 10 to 15 minutes post meal is best for your aerobic activity. 7 to 9 hours of sleep. You want to make sure screen them for sleep apnea, especially if they're snoring. And you want to do breathing, heart rate variability, yoga, CBT, any type of tools to reduce stress and physiological load. Your common supports, your myochiroinositol that we talked about, berberine. DHT is dihydroberberine. That's sort of a double dose that some companies are making now. Your omega-3 fatty acids, magnesium for sleep and stress. Magnesium, there's lots of magnesiums. We used to use magnesium taurate as a sedating salt. It's a little bit difficult to find now. We use magnesium glycinate a lot. We try to stay away from what's the one to use in the colonoscopy clinic? Magnesium
Oxide.
With the C.
Citrate.
Citrate.
Citrate, yeah.
Yeah, we try to avoid that unless they're having some, like constipation issues.
Have you ever tried malate?
I've had some patients that try it. They say they like it. I'm not sure where it fits in the hierarchy. Can enlighten us?
Oh, I've used it it's part of the protocol for Lyme disease.
Mm-hmm. Okay.
But I don't remember why. I couldn't remember how it works differently.
Okay. And then vitamin D, again, 50 to 80 is our goal. Psyllium to improve glycemia. Managing testosterone excess. So saw palmetto for females, you want to use half the male dose, so 240 to 260 milligrams once or twice a day. It does act as a 5-alpha reductase inhibitor, and it will also decrease the conversion, act as an aromatase inhibitor also. Not very strong, but it does work. My favorite and first go-to is the one in the middle, spearmint tea. Spearmint tea is an excellent 5-alpha reductase inhibitor. It will lower serum testosterone levels by 20% in less than a month.
Wow.
The key to it is, so spearmint tea, most teas have 70 milligrams of spearmint in it. I know Lipton does, and the fancier ones do too. But the key is you need 100 milligrams of spearmint tea. So you need a double bag. So a double bag of 2 tea bags in 1 cup of water once a day, usually 4 to 5 days a week. It does get a little bit old at times. You can use peppermint. It's not quite as potent, but spearmint tea is an absolute game changer. And the patients look at you like you're crazy, and the doctors think you're nuts. And I said, well, try, what's the worst that could happen? And on average, you will decrease your total testosterone levels by about 20% just with spearmint tea. We've used N-acetylcysteine. Designs for Health has a 900 milligram pill, so you need 1800 milligrams, so 2 or 3 times a day if it's a 600 milligram pill. If you're running an IV, do IV clinic, we'll do 1200 to 1800 milligrams IV over about a half hour, and we'll do that once or twice a week. And usually after about 4 to 6 weeks, the patient's testosterone levels are under control with that. For insulin resistance, we like berberine, we like cinnamon and fenugreek. Alpha lipoic acid is a pretty potent antioxidant. It usually comes with either berberine or cinnamon. It also helps support mitochondrial function, and it's useful if patients have any type of peripheral neuropathy with from insulin resistance. The immune modulators, so the plant sterolin, so like I said, Moducare. There's another one again called Wobazyme N. That's actually an enzyme. There's lots of Wobazymes. It's made by Douglas. There's lots of different ones. You need the Wobazyme N. And this can decrease antibodies by the TPO antibodies by up to 90%.
Well,
And we've done that. My world, they don't measure it this way anymore, but in 2015, I had a guy come in to see me, and we did his TPO level, and it came out, it was from Renown, 4,226. And I didn't believe it. I sent another specimen. I sent it to Access Lab in Florida, and they called me and told me that it was way over their limit. They couldn't quantify it. He's been with me. He's still with me. He's been 10 years now. His last TPO level was 101. So that's over 90% decrease. So we start out at 101, we got a problem. You start out at 4,200, 101 looks pretty good. Low dose naltrexone, we have a whole lecture just on that. It modulates overactive immune response. It is potent against just about every cytokine known to man. We use it for all sorts of autoimmune and neurodegenerative conditions. Thymosa alpha 1 is an immune peptide. It reduces inflammation. It helps with advancing immune support, and also helps to grow hair, by the way. So we talked about glutathione for detox. Milk thistle is a liver detox. Glutathione, quite frankly, is much more potent than milk thistle. Sometimes you'll see some supplements or products with a combination in them. If you're going to use glutathione, though, make sure that it's liposomal. As soon as it hits your stomach, the stomach acid will chew it up. If it's not liposomal, it'll help clear heavy metals. It's also quite potent in Parkinson's disease. The problem is that it's only short-lived. It only lasts 48 to 72 hours. But it's very good at getting rid of the tremors and the sort of the muscle rigidity in Parkinson's disease, but it's short-lived.
What dosage for Parkinson, the glutathione?
I'm getting old. My hearing doesn't work so good. Anyway, I didn't hear you.
Oh, yeah. I would like to ask what dosage do you use for Parkinson?
Again, glutathione.
Yeah, the
Yeah,
glutathione.
we like IV glutathione, and we use low dose naltrexone. We do exosomes. If the patients can afford them, they're kind of expensive. So we've had some pretty good success with that. And Spermidine is a supplement that it actually has some anti-aging properties, and it has some nerve stimulating properties. So we'll use that also.
Okay.
Environmental controls, HEPA air filters, water filters, we all know that. Road to recovery. So usually within the first 30 days, we're going to do our adrenal stress thyroid evaluations. We're going to try to start to balance our estrogens and progesterones, and we're going to add in our myochiro-inositol to address the anovulation. Days 61 through 90. Usually this is where we do the gut healing and strict elimination diet. If you have a different protocol, if you start with that, that's perfectly fine. That's where our 4 R's are. Nutrient repletion, days 31 to 60 also. B12, folic acid, vitamin D, and we want to, replenish any ferritin. Hormone optimization, not too much, not too little. If they have food sensitivities, we start to address those. And then days, 100, we kind of start all over again. So in 3 months, we'll reevaluate, and we'll take it from there. So we just kind of use that as a little bit of a backbone. So psychological component, so Dr. Klausner talked about, the patient's PTSD, panic attacks, and those need to be managed. The PTSD and panic will hijack your HPA system. So any type of stress reduction, meditation, yoga, take a walk, punch a bag. The key is, if you don't address the root causes, the endocrine system's not going to get any better. So you have to go after the root causes. Okay. So our subjective markers of what to look for is the brain fog lifting, or hair and nails improving. Also look at the eyebrows. The edges of the eyebrows with thyroid disease will start to thin out, or eyebrows becoming thicker again. Has her menstruation improved without the oral contraceptives? There's our targets again. TSH 0.8 to 2.0. Thyroid antibodies, we want that to be less than 20 from LabCorp, less than 9 from Quest and any of the hospitals that use that scale. Ferritin 90 to 110. Free androgen index 2 to 4. Total testosterone 30, should be less than 40. If the antibodies remain high, you make sure, again, you want to look, see if they have any infectious disease triggers, particularly parasites and worms. Some of the infectious diseases to look at, I mentioned them already. Epstein-Barr, that's probably number one. If they have a reactivation of Epstein-Barr, this is from Dr. Jacob Teitelbaum. He likes Celebrex and acyclovir for 28 days, 200 milligrams of Celebrex and 400 of acyclovir twice a day. And if you don't know Dr. Teitelbaum, he's the father of chronic fatigue syndrome. He wrote the first book on it in 1975. We had him at one of our conferences a couple of years ago. H. pylori, treating this has reversed some thyroid abnormalities, not all, but some. So, and this is the one that we've actually treated the H. pylori and the thyroid disease. In some patients has actually been, we can actually say cured. It's gone, but not all. Yersinia food poisoning is linked to Hashimoto's thyroiditis. Your so-called exotic testing, so 24-hour urine for halides. It'll assess iodine, fluoride, and bromine status. You can have deficiencies and excesses that can worsen Hashimoto's. Your functional stool test. So we look at the microbiome, we identify dysbiosis, pathogens, and it will also quantify digestive abnormalities. So pancreatic enzymes, fat processing, immune deficiencies and excesses. Calprotectin deals with the lower GI system. Those are all in the functional stool test. if you're going to look at nutrients, zinc, selenium, and magnesium, make sure you get red blood cell or intracellular levels, not the serum level. Serum levels don't really tell us a whole lot. There is a micronutrient panel, and again, since this was CME, I like SpectraCell. It spells it out. It gives you 32 specific nutrients, including antioxidants, neurotransmitters, glucose balance markers. There's the organic acid test. It may or may not be more effective or more specific than the SpectraCell test, but it's extremely hard to interpret. You have to. It takes me 2 hours to sit there and interpret it. I have to go through the book because they use sort of language that, some of them you get to know, kinuretic acid, all sorts of chemical names that are hard to pronounce. So again, to wrap up, there's your conventional model: failure to convert T4 to T3, inadequate nutrients. We're going to look at all of the triggers that we've discussed, find the root cause. Here's some references, and that's it. So, okay, so that's the end. We got 28 hardy souls left.
That was awesome. Really
Yes.
ran through it.
Yeah. So, what do we got here? We got some more. With this here, let's see.
Well, we probably need to emphasize to the group here that as you can see, we lecture all the time about education. So this is where the rubber meets the road, and this is where we apply all of these concepts. It's easier now to understand if you're actually practicing what you're doing. So hopefully we can see
Yeah, I
more
know.
of
What a
this.
concept, huh?
Yeah, well, hopefully we can see more of this and more engagement from our group.
I don't know if you like this kind of thing. Was this
Yeah,
It
very
is.
important. I mean,
Okay.
we cannot even treat without this information.
Yeah, it's application. This is,
Right.
we can listen all the lectures in the world and not even apply them, but this is where we actually put it to work.
So what protocol for Lyme? I'm going to leave that to you, Dr. Nario.
The shake and bake of Dr. Fung. You want that?
Another time.
The seizures,
Yeah, the seizures, the code room.
hallucinations. Yeah.
Right. Right.
Well, she was just asking what protocol recommended the magnesium malate that I referred to. I think that's why she was saying what protocol for Lyme.
Yes.
Okay.
And so then I told her where I got it from, and then I quoted the Global Lyme Alliance about how it works.
Mhm. Yeah, IV glutathione. So I spent a little time with David Perlmutter. That's where I got my protocol. I got it from him. So
Okay.
So thank you, Dr. Nario. Oral, there are no studies for IV. Okay. Celebrex, I think I told you, right? 200 milligrams. Celebrex and then acyclovir 400 twice a day for 28 days. So where do I get SpectraCell Labs drawn? So now what I do is I belong to Rupa. You know what Rupa is? It's one of those like lab aggregates.
Oh no,
And
let's write it down.
we order the SpectraCell. The patient gets it from Rupa. Rupa sends them to a lab wherever it is, and I don't have to deal with it. So,
Okay, that's what I wanted to do, is not deal with it.
yeah, I don't have to deal with it. So before any of those, I had the kits in my office, and patients would come and we draw the blood, send it out. I mean, that's what we
In
did.
Texas, there was a place called Any Lab Test Now, and they had a contract with SpectraCell, so I could just send the order over there, and they would totally take care of it. Because I think it's got to be in a special fridge too. It's whole and
I know it's been a while. I know they had
be especially cold, I think.
they sent a kit and they sent the what to pack it in. But it's been a few years since I've done it. Like I said, there's a couple of them. Does Avexius also do the lab thing? There's one of them but you have to pay them, to be a member of it, which, who needs that?
That seems silly.
So Rupa, you don't have to pay them, right?
Uh,
And you can have them charge you for it if you're allowed to charge for lab tests, or you can just tack on a reading fee.
Yes.
You know, if you don't want to deal with any of the stuff. A lot of those tests are, I guess, insurance takes.
This is Rupa, RUPA
RUPA, yeah, Rupa Health.
for
So
Spectral Cell.
it just made it much easier. I mean, they have, I used to have accounts with Genova and SpectraCell and designs for health or doctors' data, and now they all their tests are there. So
Oh, at Rupa? You send them over. Okay.
you type in you type in GI test, and there's 7 companies.
As you can see, these local spicy and exotic dishes have been especially prepared for you by my famous chefs. They will be in.
What's that? What's that?
That's John watching YouTube videos.
Who's that? Who's watching the YouTube videos?
John.
That's funny.
Are we boring you, John?
Yeah, I don't add on to the charge of these stuff, but I can add it to a separate fee in my own accounting, but I don't.
Yeah, you can put it on. You can put the fee on there, and they'll send you the money.
Oh, yeah.
So it's kind of buried in the price there. So I don't know. I usually put $49 on there. I mean, I don't put anything exorbitant on there.
Yeah.
But they have the Dutch test on there. They have, Access Labs is on there. SpectraCell's on there. I mean, even Quest is on there now.
Oh.
You can order anything from Quest through them too.
So do you know where this place is in Reno? It gets a location, right?
Rupa Health?
Yeah.
It's not in Reno. I don't know. I don't know.
Online.
I don't know. They're online somewhere. They're out there in
She
cyberspace.
comes to A4M conference.
I mean, they have a drawing state. So there's an outfit called Cash Clinical here, and they do it's like a drawing station.
Oh, okay.
And also, and Renown will draw it for you too from them.
And you just give your NPI, Janet, and then you go to rupahealth.com, so you can open up your own account.
Okay. And
then same for FullScript. If you remember FullScript, they're now offering lab testing as well.
Yeah, I did see that, but I haven't ordered anything through them.
Yeah, but not as extensive as Rupa. Rupa has
Okay.
I mean, but they're merging though. I've been hearing about that Rupa and FullScript will be merging soon.
Well, what's nice about FullScript is that they will draw all the graphs and the trends in the system, which is really nice.
Yeah.
But I haven't ordered anything from them exactly for the reason what you're saying. It's not very extensive.
Yeah. Rupa Health still has had the most of it.
So you know what happened? You know what happened with me and FullScripts, right?
Your cannabis thing?
Yeah.
That sounds like a crazy story.
Well, right. Well, so we had changed our phone system, and it was maybe 2 to 3 months after the AOA threw us out, and then they just, someone was after me. I came in one day, and all of our communications are shut off. The text messages, we had one phone line that was working, that was it. And everything else was done. The text messages, the inter-offer, everything was shut off.
Wow.
So, well, first we thought, well, there was a short, there was an electrical thing. So we call, and we had a new system, right? So we call the people who are running the system. He says, "Oh no, the FTC has flagged you as being a marijuana dispensary, that you're dispensing marijuana illegally." And they shut you down. I said, "What are you talking about?
Wow.
Marijuana dispensary? What are you? I have no idea what you're talking about." Right? So they said, "Well, we don't know. So go try to find somebody to get an explanation." So it took like 2 weeks before I finally got somebody. And meanwhile, we got nothing.
Right.
So we finally found somebody on the phone, And they said, well, you're a marijuana dispensary. What are you talking about? So we had a full scripts account.
Oh,
And when you open a full scripts account, they make the website for you, and it's called Dr. Clearfield's dispensary.
oh, wow.
So someone, and I suspect I know who it was, reported me as running a marijuana dispensary, and that's what they used. So I said,
Wow.
so I called Full Scripts. I said, "Do you know anything about this?" And they said, "No." If you go on their homepage, it says we have 70,000 practitioners running the dispensary that they have, right?
Oh, wow.
So I said, "Do you know anything about this?" And he goes, "No." So I told them about it, and they actually did the legwork for me. They said that Designs for Health had one product that was it was some sort of CBD, wannabe product. It said echinocannabinoid something or other. It was a powder. So they decided that since I had a Full Scripts dispensary, and that was in Full Scripts, I was a marijuana dispensary.
Wow. Well, they're really desperate to hang you.
Yeah, I suspect I know who did it. It was one of the guys who stood up at the AOA meeting and told everybody that we were so backwards we didn't have a website, that our program in Seattle, the program that we ran in Seattle was really substandard, and it was an embarrassment to the AOA.
What is AOA?
I asked them, I said, I've never been in Seattle in my life. What are you talking about? I've never even been in the airport to change planes in Seattle. I don't know idea what he was talking about.
What is AOA?
American Osteopathic Association.
Okay.
We're not the
It's that
MDs, we're
trend.
better,
Oh, I agree.
If you go on their website, they'll tell you about how they're the progressive and open-minded medical society. They're like Avis. They're not Hertz, they're Avis. So, yeah. So anyway, so that was me in Full Scripts.
Wow.
So I have Full Scripts PTSD. Start to shake.
That's too bad. I was very relieved when they finally started doing this, so I don't have to keep inventory.
Yeah, well, there's that. I actually like keeping inventory, so I don't mind.
I don't mind it, but I've got other things to do, and I don't want to pay somebody else to do it.
Yeah. So, okay, we're going on two and almost 3 hours here. It's almost like a halassa night.
Well, thanks so much. I really like this format.
Okay, so
That is one of the
we'll
hardest
do it
things.
again. We'll get Dr. Quinn to do one of these for us. So, right.
Okay.
So, okay. All right, everybody. Thank you so much.
Yeah.
I want to join Dr. Halassa group too.
They're on Monday night.
Yeah, he told me
Okay.
to text him on his cell phone, but I didn't write his cell phone.
I got a link somewhere. I'll let him know. Okay.
Okay.
I'll send him your website or your email address.
Thank you,
Okay.
Doctor.
All right.
Okay.
Everybody have a good
All right.
night.
All right.
See you
Good
next
night,
week.
everybody.
Okay.
night.
Bye-bye.
Thank you, Dr. Nario.
Thank you.
Good night. Good night.